Hi, I'm Ken Howard, the founder of Gay Therapy LA, and today, on today's episode 12 of the podcast, I would like to discuss gay men and erectile dysfunction, cognitive causes and cures. I've been a therapist who specializes in therapy for gay men for over 27 years, and one of the most frequent topics discussed in my office is about sexual anxieties, in particular erectile dysfunction, sometimes in the past referred to as impotence, other times referred to as can't get it up, problems down there, lots of different euphemisms for that, but, it's an anxiety that gay men have, and all men, straight men too, certainly. And there's this myth that it's a problem only for older guys, that, older men can't get it up and all this other stuff. And so it's even more anxiety provoking for younger guys when they struggle with this. And there's also, not only is there the problem, but there's also the problem of guys feeling isolated. They can feel very sheepish and very embarrassed or whatever to talk about this with their physician or with their therapist. And there's a lot of therapists, especially mainstream ones, that can't or don't want to talk about this stuff, and even some gay therapists that can't or don't want to. They just find it awkward. Therapists in general are not really trained about a lot of sexual issues. And as of this recording of this episode in the summer of 2019, I'm really kind of in the middle of the process to become a certified sex therapist through ASECT, the American Association of Sex Educators, Counselors, and Therapists. But I've been working with validating gay men's sexual concerns for a long time. I'm just formalizing it with the certification to fill in some details, because what I found where I am in my office in Los Angeles County, even though I provide services through phone and webcam all over the country and all over the world through coaching, which is kind of a different thing because of licensure issues. I'm only licensed in California. But, sex therapy is kind of its own thing, and I'm one of the few people, one of about 3 or so in Los Angeles, that are kind of able and willing to deal with this stuff. And it's really important because the problem of problems with sex in general and erectile dysfunction in particular are much more common than there are providers that can help guys with this. And I really like to help people with sex therapy and sexual dysfunction issues, because I really believe that sexuality is a part of our quality of life, just like the ability to eat, or the ability to pee and poop comfortably, or the ability to have mobility without pain. I've talked about chronic back pain. So we really look at erectile dysfunction as a part of a healthy sex life, and we look at a healthy sex life as really part of your subjective quality of life. Having a good time of it in your life, and really believing, as Louise Hay used to say, that life is here for us, that life is meant to be enjoyed. So for guys who have these kinds of sexual problems, we want to validate that, and we want to troubleshoot them, because we believe that they deserve to have help and to overcome them as much as they can be. So, too often, doctors and therapists assume that ED, or erectile dysfunction, for straight men and gay men are the same. They really aren't. I have articles on gaytherapyla.com that talk about the difference between gay and straight relationships, and some of the observations I've made over many years of doing couples therapy with gay men. And there are differences. Some therapists like to say a couple is a couple is a couple. Kind of. When I teach the couples therapy course at USC in the graduate MSW program, we talk about this. Some of the couples therapy techniques will work, from heterosexual couples to lesbian couples to gay couples to trans couples, whatever. But there's also some individual cultural competency, we call it, considerations. And gay men have additional stressors from minority stress that can contribute to ED. And any therapist who is really culturally competent in LGBT affirmative therapy in general, and gay male affirmative therapy in particular, would really do well to consider these kinds of minority stressors. So the gay men that I work with describe the frustration, disappointment, misgivings, and demoralization that ED causes them, that affect their overall quality of life, whether they're single or in a relationship. And it's an important issue to work on in therapy because ED can have implications for your overall mental health and quality of life outlook. Just like the value of coming out as gay men, we have to affirm our right to have a satisfying and rewarding sex life, even when aspects of society want us to deny us that, or even deny us basic rights, including the right to live with some rhetoric, it gets that extreme. But just like coming out as gay in the first place, asserting that we have a human right to sexual expression, sometimes we have to reaffirm that right and get help when we face the phenomenon of any sexual dysfunction, premature ejaculation, low desire, inorgasmia, inability to be penetrated. I did another episode on the fear of bottoming, another one on the fear of topping. If you look at the list of podcast episodes, there can be anxiety, panic disorder, all of those. But today we're looking at ED, or erectile dysfunction. What makes ED complicated is that it can be influenced by physical, mental, emotional, interpersonal, developmental, cultural, and social factors. So the reason one guy struggles with it might be different from the reason or reasons another guy does. This is one of those topics where two professionals, such as a therapist and a physician, might work collaboratively with your written permission to share confidential patient information under the big HIPAA law. And each provider contributes to the solution to the problem from their own discipline or areas of expertise. So ED can be lifelong, in your adult life since puberty, or acquired, meaning in relatively recent times. It can be generalized to all sexual activity, or situational to certain sexual acts or with certain sexual partners or types of sexual partners. For example, if you never have morning wood, you don't get fully erect when masturbating, that is generally considered a more pervasive medical style problem that might have to do with the levels of total or free testosterone in your bloodstream, other hormonal issues, blood circulation issues to the penis, or perhaps another medical condition. If you only have erectile problems during certain types of sex, such as insert of anal sex, or with certain partners, like you get hard with tricks but not your own primary partner or spouse, then that generally points to what we call a more psychogenic origin, meaning originating in the mind or from a psychological cause. So when I work with gay men with ED in my office in LA and West Hollywood, first, we ethically must rule out a physical or medical problem. We don't want to treat you in therapy when what you really need is something like testosterone replacement therapy, also called TRT, because of a low testosterone count, or you might have some kind of a blood flow or medical problem. So in many cases, receiving a prescription for ED drugs like Viagra, also called sildenafil, Levitra, Cialis, sometimes that'll just do the trick. I worked with a guy last year who, came to me for these concerns about ED. He got a prescription for Viagra, and that was fine. End of story. He used Viagra, and that was all the work we needed to do. But, some guys have feelings about relying on a pill every time for sex. For some patients who don't respond to the pill format, there are injectable medicines or combinations of medicines like Caberject or Trimix or Quadmix, which is a mixture of several different kinds of drugs that's injected into your penis. Yes, that's as painful as it sounds. And that's for more stubborn cases. But those kinds of medications that are mixed or compounded by a pharmacy and then injected into the penis with a very, very tiny insulin format syringe, that will increase blood flow to the penis and give a guy an erection, sometimes too much, which is another whole issue called priapism. But and these won't help with arousal or your libido, but they will cause increased blood flow. So in a situation like that, and really with all of this, I would encourage you to talk to your general practitioner, MD, or maybe even a urologist or an endocrinologist, a hormone doctor. And there is a resource, like I'm going to sound like a commercial now, so forgive me, but Defy, D-E-F-Y Medical Group in Tampa, Florida, conducts telemedicine services. They are at defymedical.com. I have this service. I work with one of the physicians there, Dr. Justin Saya, S-A-Y-A, and he kind of oversees my testosterone replacement therapy and prescribes a couple of other medications that help balance my hormones as a guy over 50. I need that. I have a husband who is on testosterone topical gel. So it's not unusual for guys, whether HIV positive or HIV negative, to need some kind of testosterone supplementation, either in the gel or in the injections, or sometimes in a under the skin time release pellet. That's another what we call method of delivery. If low testosterone is an issue, and it can be for not only older guys or middle-aged guys, but sometimes younger guys need this too. And Defy Medical treats guys, of all ages, and they don't invalidate it. A lot of guys go to their doctors, and their doctors say, well, your testosterone's in the low normal range, so, quit your griping. And you hear how invalidating that is, because for guys who suffer the sexual and the confidence and even the mood effects of hypogonadism, meaning low testosterone or low hormones, it can make a guy feel invalidated and isolated with a pretty serious problem if he's not able to enjoy his sexuality as part of quality of life. But if your MD rules out any obvious medical issue, like your testosterone is very strong, everything looks good in terms of, your physical state, then the ED is more likely the result of an emotional or a psychological dynamic, and this is where it gets complicated. And this is where the transition might go from a physician treating you to a psychotherapist treating you, especially one trained or in sex therapy. So let's look at the psychological contributors to ED. The psychological contributors to ED can be many in men in general, but like I said, in gay men in particular. The classic cognitive challenge in ED is about thoughts and beliefs about performance anxiety and a deep belief in socially demanding expectations of ourselves or what we think others have of us, such as, I must be hard all the time or I'm not a real man. The connections among ED and our self-esteem, self-concept, self-confidence, and self-worth are complex and can take some discussion in therapy to tease out and assess meaningfully and in some detail. These thought patterns and core beliefs about yourself can be very individual to each person, which is why they need discussion to see exactly which dysfunctional thoughts that you carry around in your head are sustaining the ED for you. Now, there are many theories about the kinds of negative thoughts a guy can have that might be contributing to ED. There can be assumptions that a man must always be hard in order for him to be seen as sufficiently male or masculine. And while straight men can have a struggle with this, it's exacerbated for gay men who might have been bullied or at least criticized in their history for not being masculine enough by family, especially fathers, teachers or coaches, or peers, which could be male or female. This idea that gay men aren't really men, or that gay men aren't man enough, and all this kind of toxic masculinity stuff. And there's a blog article I have on toxic masculinity if you're interested. And gay men often grow up with the collective pressure to butch it up into gender-conforming behavior. And this pressure for many years of development over a long time can contribute to ED later on as sexual adults. Now, fortunately, in the current generation and in the current zeitgeist, this is changing some. For example, trans women who retain their penis and who top give a whole new meaning to being erect and its implications for masculinity versus femininity. There's emerging cultural acceptance that seems to say, my penis is my own and I will use it how I please with another consenting adult, which is another important consideration about consent, what's getting increased visibility these days. But despite some social progress in what makes a man, or the care and use of the penis, for many gay men, the size and function of his penis can have strong implications for his self-concept, how he's experiencing himself in life. So let's look about ED in relationships. Another cognitive challenge involves unconscious dynamics in a relationship with a partner. For example, a classic scenario I see in my office often with gay couples is where a guy can have ED if he has an unconscious, unacknowledged anger at his partner. There have been several guys I've worked with who have worked in big jobs and made more money than their partners and can feel that their partners who don't work or work as much are not really contributing enough to their household, burdening them with paying all the bills. And there's another blog article and another podcast episode about this, when my partner is not contributing equally. Maybe you heard that in the last episode. Or we might be angry at a partner who has a drug or alcohol problem that they're doing nothing about. And that can lead to ED because of the underlying resentment they have toward their partner. It's very difficult to be relaxed and aroused by someone that you're angry at, even unconsciously. The joke I sometimes say, because I can be a little maybe irreverent in my humor, but I say you can't lie to your dick. It's that your true feelings will tend to be expressed in terms of your penile and erectile functioning. So other cognitive contributions, your thought can be thoughts about low self-esteem, feeling that you're not good enough or deserving of a domestic partner or even a sex partner. And so the ED is a manifestation of that lack of confidence about your value and worth as a person or as a man, which may be related to internalized homophobia, the long-term effects of bullying or some kind of social persecution against gay men or gay boys. Other types of personal trauma, combat veterans maybe, or survivors of rape or violent crime or natural disasters or other kinds of trauma like 9/11 was. Or feelings of low self-worth for other reasons, such as physical traits, not being happy with your appearance, your perceived intelligence, your talents, your social status, your income, your penis size. All this stuff about feeling deserving to be a sexual being, which we have to restore. Everybody has a right to be a sexual being with another consenting adult. Still, others might have family of origin or religious guilt that is preventing them from functioning erectilely, or an internalized homophobia that makes them ambivalent about having any form of gay sex, wanting it naturally but hesitating due to what they've been taught, and the internal conflict impedes a relaxed, confident sexual performance. Guys with internalized homophobia can be conflicted about what they're allowing themselves to have sexually, without feelings of guilt that they are betraying their parents, or their family, or their church, or their peers, or other social expectations of heterosexism. We define heterosexism as the assumption that everyone is or should be heterosexual. And we see that in society all over the place. That was coined by a guy named Gregory Herrick, who really influenced a lot of my early studies. He was from UC Santa Barbara, and I think he's still around, a gay therapist, who defined the problem in society, that persecutes gay men. Is it's not just homophobia, the irrational fear or the irrational antipathy against gay men. It's actually heterosexism. It's holding out that heterosexism, or that heterosexist relationships are the only legitimate relationships. And we see this practically constantly, particularly in things like the Catholic Church or the Republican political party or the evangelicals, or even among Hasidic Jews, and even among other types of religions that say only the relationship for procreation between a man and a woman is legitimate. We saw that in the marriage equality opposition. So we grow up with a lot of messages that if we're not having a heterosexual relationship, and more specifically heterosexual sex, that our sex is not legitimate. So we get that kind of invalidation for our sexual performance, and that's something that a straight guy with sexual performance or D issues would not have. Ours it would be a cultural influence. So let's talk about ED thoughts and expectations and contributors. So ED can also come from gay widowers who, might be struggling with thoughts that they are betraying a partner who's died. I saw that at the height of the AIDS crisis. There's a really good book on gay widowers by Michael Chernoff, who was Shernoff, if you're interested. Michael Chernoff was a kind of a legendary gay specialist therapist in New York, especially during the height of the AIDS crisis, and died a few years ago. But really was a prolific writer, and he talked about the issues for gay widowers, guys who lost partners, during the height of the AIDS crisis or through anything really, combat, car accidents, other kinds of illnesses. But being sexual again after the death of a partner can be significant. I've worked with guys on this. You have to reclaim your right to a sexuality while you still love and honor the memory of a lost partner. So therapy then becomes about having closure with the bereavement process of the loss of the partner, and understanding that surviving a lost partner can include all aspects of living, including sex. ED can also come from thoughts and expectations about oneself as the nice guy, and that nice guy doesn't hurt his partner or exert dominance over him as a top in oral or anal sex. I explore this more in the podcast episode about the fear of topping, if you want more on that. And this can involve a history of social pressures that gay men must always capitulate, defer, and lay low in order to survive, and let others control or dominate. This therapy involves understanding the playful dynamics of dominance and submission in sex, and that sexual roles in dominance, even in BDSM play, there's another blog article on that called Fear No Leather, the benefits of BDSM play. They don't actually imply hurting your partner in a serious way, but experimenting with the dominant and submission dynamics as a form of intimacy and sexual play, that can be exciting and really satisfying, even if the partners have otherwise a very egalitarian relationship. The classic couples therapist Esther Perel, Perel, in her writing, especially Mating in Captivity, kind of a classic book, she says that couples need to be on an equal footing in every other room of the house except the bedroom. In the bedroom you can play with dominance and submission dynamics and the eroticism and the fun of that. Other guys I've worked with have been in recovery from a crystal meth addiction, and they have ED because they are still getting used to sober sex without the extra stimulation of meth. And without the extra stimulation, sometimes sex can be boring for about the first year, being clean and sober, sometimes less, but 12 months is kind of the rule of thumb among other body parts. This can mainly be about physical stimulation from the effects of ingesting amphetamine, but it can also have cognitive implications when a person is in recovery and they associate the rituals of using drugs with rituals in sex. So a guy in recovery might stop using drugs and everything that's associated with that, with meth, but he might continue to be a sexually active person. So the sex and the drugs have to be kind of pried apart after they've been fused together for somebody who's had a crystal meth addiction. I've worked with a ton of guys on that. And again, it's about reclaiming. You have to reclaim your right to be a sexual being, to be a sexually active person, man, guy, with a consenting adult partner, even though you may not be using drugs along with it anymore. So these are just a few, but are among the common thought or cognitive themes that I see with clients. Now let's look at the interventions for improving erectile dysfunction. What do we do about this? And I always say that too many articles in self-help books focus on defining and describing problems rather than giving practical solutions about what to do about them. Articles that are, blogs can be of some help, but they're not a substitute for either medical or professional mental health services. So, anything that you read or listen to, like a podcast like this, that only goes so far before you actually have help in this area. So cognitive behavioral therapy has been known to have positive outcomes in the treatment of male sexual dysfunction. There was one study where the proportion of men reporting dysfunction decreased from 71.1% at the start of treatment all the way down to 35.6% post-treatment. This is the work of McCabe in 2001, fairly recently, and even more recently in the work of Hart and Schwartz, if we look at our research, research-informed practice, which I do. At Gay Therapy LA, my associate clinicians, whom I employ and supervise as part of a group practice, we only use evidence-based treatment with our clients. Techniques that have had proven efficacy in formal academic research. As opposed to techniques from other therapists, sex addiction comes in mind, which is the biggest malarkey. That's not evidence-based practice, and they're really just, commercial charlatanism. And I have an article about that. The classic book, The Myth of Sex Addiction by David Ley. Isn't that a funny name? He's a great guy and a brilliant author. I just think it's funny that his name is Ley as in get laid. Anyway, it's Ley. But, things like sex addiction are not an official diagnosis. It was made up by a rather homophobic pioneer who capitalized on expensive recovery programs like the Betty Ford Center and really capitalized on AIDS hysteria fears in 1983. While, ED is an official diagnosis in medical journals like the Diagnostic and Statistical Manual of Mental Disorders and the International Classification of Diseases, and it's called Male Erectile Disorder Acquired, Situational Due to Psychological Factors. And that's from the American Psychiatric Association. So because of that, health insurance plans, unlike sex addiction treatment, do cover psychotherapy as being medically necessary, a reimbursable treatment. Especially with me, you have to have out-of-network provider benefits to see me, but in-network people might do this. But, in general, when you're talking about these services, unfortunately it's expensive because you're normally talking about specialized providers, and specialized providers that are more rare are a little more expensive to deal with. So that's one of those healthcare services delivery issues that becomes a part of politics for a long time now. But some of the benefits of cognitive behavioral therapy for ED have included reducing anxiety about sex, reducing attention to sexual performance, the self-consciousness. It can be education about sexual issues. It can help improve communication with your sexual partners. And it can help you with something called sensate focus, which is the ability to focus on the pleasure of the moment, which goes back to the classic sex therapy, pioneering work of Masters and Johnson around 1970, and before and after. So, kind of classic approaches to sex therapy. It can also be, the CBT, about developing more positive attitudes about sex, more pleasure during sex, less feeling like a sexual failure, or feelings of inferiority compared to other men. One place to start improving this process is to think less about negative thoughts about sex or erectile performance and think more about the thoughts you had during times in your past when sex was good or satisfying, maybe when you were younger. This will take the focus off whether you do or do not have an erection, but will get your thoughts in a more positive mindset in how it relates to sexual situations. So think of situations in your own past where you have felt and thought sexually confident, relaxed, comfortable, in the moment, and having fun. And revisit that time both cognitively in your mind and imagination and sensorially in your body. What did it feel like to have good and confident sex at one time? Other thoughts for gay men can be ambivalence about being a top, like I said, the fear of topping podcast episode, and having anxiety about the expected performance of a top in insertive anal sex. Guys can feel a certain performance pressure about whether they're hard enough or doing it right or satisfying their bottom or dominating enough, and even fear of hurting their partner, especially if they're well endowed. So this focus on the self and the related anxieties are almost exactly what not to do. Mindfulness really comes into play here with less emphasis on evaluation of your performance role until later, if at all, but in the sexual moment to be mindful and focusing your attention on pleasurable sensations like touch, sight, sound, smell, taste, and pleasant emotions you experience, such as excitement, affection, enjoyment, and for tops, maybe the fun feelings of being in control or pleasuring a guy with your own penis and body and hands and verbal commands or erotic talk. It also means ignoring any stressful or intrusive thoughts such as worries from the previous events in your day or the anticipatory anxiety of something that you may have to deal with later on that you're dreading or preoccupied about. Mindfulness means being sensorially aware of what's going on in that moment for both yourself and your partner. I stole that from Cohen in 2017, his work. Citing, rather. We don't like to say stealing. I should say citing. C-I-T-I-N-G. So taking some of the pressure off yourself when you're topping can be important. Instead of a thought like being a top means being in control, experiment with a variation like someone else can do some of the work, or I am actually happy when there is a balance of control. This is what Hart and Schwartz said in 2009. So, ironically, the less pressure that you're under to perform sexually, the better your performance will be. It's a paradox that way. So let's talk about the role of couples therapy, or also known as conjoint sex therapy, two people in the therapy room. If your ED is related to relationship problems, then couples therapy can help, alleviate that. Sometimes when I provide therapy for gay male couples, if they're having sexual problems and having fights and arguments about other issues, when we work on the other issues first, suddenly their sex life improves without us necessarily doing sex therapy as such. So discussing where the resentments are of each partner toward the other, discussing what is fair in terms of how money is managed or how household chores are divided, or working on the relationship on what I call 4 levels. There's another blog article on this. The 4 levels are the emotional and the romantic, the physical, including the sexual, the domestic, meaning sharing chores around the house and dealing with money, and then a 4th one that I call managing the other, stressors that impede on the relationship from the outside in. And working on all of these, separate from what's going on in the bedroom, can actually help your sex life kind of indirectly. So the couple dynamics often need to be discussed, and they fall in general themes of things like trust and intimacy, control and dominance, role conflicts, alpha beta roles, or even gender roles, because with 2 gay men there's no women, so what is more masculine, what is a more feminine role around the house? Certainly communication skills. Most couples therapy really is about improving communication skills as a way of solving problems creatively. And then there's ongoing support and relapse prevention. It's not just changing the dynamics of the couple in the short term, but it's sustaining it for the long term, which is actually the more challenging thing. So, again, these interventions for erectile dysfunction assume that there's no physical ailment going on, such as heart disease, diabetes, obesity, hormone problems, cancer, circulation problems, mobility problems in your back or hip or anywhere, or any other medical causes, including psychiatric disorders like a clinical depression or a generalized anxiety disorder, bipolar disorder, stuff around OCD, about cleanliness or obsessions or compulsions, ADD, the role of ADD in sex is sometimes discussed, or any other, psychiatric condition. But it also assumes that things are okay regarding alcohol and drug use, and that the ED is not just the direct result of a substance abuse problem. While some authors, especially sex-negative ones, have asserted that excessive, of course we have to define excessive, right? That's very subjective. use of porn contributes to ED, that's really a myth. So another book by David Ley, our hero, is called Ethical Porn for Dicks, a man's guide to responsible viewing pleasure. And it really kind of explores this scapegoating of porn as being the great evil of the universe. We see a lot of that, especially from straight women on both the left as a feminist kind of thing politically, and on the right, women who are religious conservatives, and they really just vilify men, gay and straight, who view porn. And it's just not that simple. Viewing porn is a very complicated thing. The work of Joe Kort, K-O-R-T, has been very good about putting porn use in perspective, and certainly David Ley's book. So I hope this gives you an overview about what ED for gay men is about, and some, not all, of the ways that a therapist or a coach can help you overcome it and enjoy a more confident and rewarding sex life. But for an individual consultation with me, feel free to reach out. Email me, ken@gaytherapyla.com, or call me or text me. I kind of prefer text because it doesn't make my phone buzz during sessions. But, feel free to get in touch. Area code 310-339-5778. So that's 310-339-5778. Or you can email me from the pop-up box on my website at gaytherapyla.com, or just send me an email, ken@gaytherapyla.com. So I hope you found this helpful, and as always, thanks for listening. If you have comments or suggestions, let me know, especially suggested topics you'd like to see me cover in a blog article or a future podcast episode, and I'd be happy to help you out. Thanks again.